continuing medical education webinar series for ComCare professionals. If you have missed any of the preceding topics, such as dementia, end-of-life care, Parkinson's, and many other interesting webinars, you are able to watch them on YouTube. And we would also like to invite you to participate actively by sending your questions on the Q&A section and filling out a survey to share with us future topics and speakers whom you would like us to invite onto this webinar. Time flies. Home Nursing Foundation is turning 50 years this year. And from the time we were incepted as a charity by then Minister of Health, Dr. Toh Chin Chye, till today, where we serve more than 5,000 home care patients each year and 3,000 seniors communities in Serangoon, Hougang, and Buangkok through our daycare, community rehab, CREST, and active aging centers. We are most happy and proud to have all of you with us on this journey to make quality care accessible and sustainable in the community. So please mark your calendars and join us at our signature third Caregivers Conference this year, together with a commemorative gala dinner on the 4th of September at Gardens by the Bay. We look forward to seeing you in person there. And right now, I'd like to hand the time over to Dr. Ng Wai Chong, who will be introducing our kind and generous speaker, Dr. Goh Wen Yang, and today's topic, which is highly relevant to all of us community practitioners.
Thank you, Christina. So today, it gives me great pleasure to have with us Dr. Goh Wen Yang. He's been helping Home Nursing Foundation in our work on integrated home health, which was a pilot program provided by tour board guided by AIC on generalist palliative care for homebound elders. And so far, it's been quite a success. And recently, HNF won an award from Sing Health for this particular piece of work. Dr. Goh himself, he's a geriatrician and a geriatric palliative care physician practicing in Tan Tock Seng Hospital. He specializes in geriatric oncology as well as palliative care for organ failures. And today he's giving us a very important topic. All of us practicing in home care and maybe perhaps in nursing homes, we may find it very useful. That is non-parenteral approach, without needles in managing complicating difficult symptoms in people near the end of life. So Dr. Goh, please. Oh, sorry, before that, I'll just briefly share about our procedures. So Dr. Goh will give a lecture for about 45 to 50 minutes. And after that, we will open to the floor for Q&A. So we encourage you to use the Q&A function at the base of your Zoom screen to ask your questions. And then I'll moderate the session. Dr. Goh, please.
Hi, everyone. Thank you, Dr. Christina and Dr. Ng, for your kind introduction. Let me share my slides first. I hope everyone can hear me properly and hope everyone can see the slides. So as mentioned by Dr. Ng, today our topic will be needle-free pain relief. When we talk about palliative care in the home setting, this is an important topic, especially when many of our older adults are very keen to, in a sense, pass away at home. So in this topic discussion, we will navigate non-injectable analgesic routes when intravenous and subcutaneous options are not available. So thank you once again for spending time with us on a Saturday afternoon. And I would like to make this disclosure that I'm not affiliated to any of the medications or pharmaceutical companies that may be discussed during this presentation. Let's bring in a case to contextualize our discussion. This is not any particular case, but one that our integrated home health handles every day. So we call this lady Amma. Amma is a 89-year-old lady who used to sell vegetable in a family-owned wet market store from when she's much younger to old age. She aged very well and was still physically fit with a strong commanding voice that was over everyone else's voice in the market. Unfortunately, she suffered from progressive hearing loss and then progressively got more forgetful and eventually was diagnosed with Alzheimer's dementia. Despite of this, she was still active in her community, but eventually she became more debilitated over many years. She disliked staying in hospital, but unfortunately, as her dementia progresses, her cognitive dysphagia got worse, and she suffered from recurrent aspiration pneumonia. As you can imagine, in your personal experience in hospital, whenever such a feisty lady gets admitted, vulgarities will be all over the ward, and everyone alongside with her will suffer. So this includes herself, includes the healthcare workers, and includes her family members who will be like frankly apologizing to everyone in the healthcare team whenever she acts up. Yeah. So this day, when she was at home with her family calls in our home medical helpline, and she was having fever with high respiratory rate and desaturation at home. So unfortunately, she had been admitted 5 times in the last year, and there were multiple conversations with hospital doctors as well as the home medical team. And this was also brought home to be internally discussed, mainly for what we call as the goals of care discussion. Amma's family decided that enough is enough. They decided that will not bring her back to hospital anymore, and the family is, of course, very sad with regards to this decision, but they feel that this is the best and feel that this is what they need to do for Amma as a family now, meaning that to really honor what she really has expressed, that she doesn't like to be in hospital, she doesn't want to be in hospital, and of course, with this recurrent admissions for aspiration pneumonia, how much treatment can be done, how much benefit will each treatment help, and how much she has to suffer. I think these are the recurring themes that are in the family's mind that led them to make this decision. So, with the O2 saturation being low, our home nursing team brought in oxygen for Amma, and with that, her breathing got slightly better. So initially, I think the respiratory rate was about 34 breaths per minute. Sort of, this with the oxygen supplementation it had a significant improvement. But with her mixed delirium, it is difficult to feed her oral morphine in the first place. And when anything gets into her mouth, her tendency is to spit it out. Hence, without any form of oral, intravenous, or subcutaneous access, is there anything else that we can do for Amma? I think this for this context, we will need to bring in a bit more with regards to our integrated home health to let everyone know why is this important. As you may imagine, if you are familiar with our local home hospice services, actually subcutaneous access is available. Our home hospice services are able to provide patients with subcutaneous injections as well as start subcutaneous infusion if necessary. However, for our integrated home health, such medications are not available, and hence the difficulty in trying to manage symptoms at home if there are no such access, if hospitalization is not an option, and if there is no NG tube and patient is in a delirious state. So for today's discussion, besides the oral routes, we will discuss on the other routes of administration of opioids that are available, they are around in the literature, but not necessarily available. So these routes includes intranasal, buccal, sublingual, transdermal, as well as rectal. Towards the end of the presentation, I will wrap it up with a short spiel for epidural as well as intrathecal. Before we dive deeper into each route, there are a few pharmacokinetic theory that I will need everyone to be familiar with. The first actually is with regards to half-life, which is essentially how long does the medication last. This essentially has an implication to how often should we dose our analgesia to prevent the concentration from stacking up. So later on, when we talk about specific medication, I will let everyone know with regards to different types of medication, how long the half-life of each medication will last. The second concept is with regards to the onset of action. This is largely affected by how the drug is administered and how it is absorbed in our body. So usually, intravenous route is the fastest, and the onset usually comes within few minutes. Subcutaneous is the subsequent fastest route of administration of medication, and oral administration will be slower. And as you can see, transdermal administration of medication is actually one of the slowest as well. As we can see in the next diagram, um, the intravenous route, we take this graph with the x-axis as time and y-axis as the plasma concentration. With intravenous administration of medication, as we have discussed earlier, the onset of action is the fastest. The concentration of the medication in the body will peak within a few minutes time and drops the fastest as well. Hence, we need to have good understanding of how fast the medication will peak, as well as how long the medication will be sustained within our body, to have an understanding how should we dose our medication and why are they dosed differently. So lastly is with regards to bioavailability. So this so the concept of bioavailability is for which where the medications are absorbed via the GI tract mainly. So medications that are absorbed via the GI tract, the gastrointestinal tract, actually undergo first pass metabolism when they flow into the portal vein system. Essentially, this means that the liver works on the medication to change its property so that it can render it either more effectively or less effectively. So this will have a difference to the original drug that was administered. So this first pass effect does not affect medication given via intravenous, subcutaneous, or the other injectable routes. And we will see later how the other novel routes of administration complicates the bioavailability. So let's apply the pharmacokinetic principles to oral morphine. We go through some form of basic pharmacokinetics first before we talk about the other form of medications. So oral morphine, most of us are quite familiar with. Firstly, I wanted to let everyone know that morphine is the common starting point for medication for opioid usage in palliative care setting. It is a good denominator to use when we want to change opioids. It is very commonly used for pain and breathlessness towards the end of life. Morphine itself is also a mu receptor agonist that can, like what I mentioned earlier, help with pain and breathlessness. Usually, we start at a low dose of 2.5 milligram. It takes about 30 minutes to work. As mentioned earlier, anything that is taken through the enteral route, meaning through oral or NG, nasogastric tube, it takes about 30 minutes for the medication to be absorbed into the bloodstream and takes its effect in the relevant receptors in the body. The half-life of morphine is roughly about 4 hours, so the effect of the medication will last for at least 4 hours. So you know that those who take oral morphine and essentially tells you that once I've taken the morphine and within 1 minute, the pain got so much better or the breathlessness start to improve, may not be reporting truthfully. And we know this really because we know how the pharmacokinetic works and we know that it doesn't respond so fast as well. The main side effect of morphine is that of constipation, and as the saying goes, that the hand that prescribes the morphine must also write the laxative. Before we move on to the other medication, here are a few more pearls for prescribing analgesia towards the end of life, which can be applicable to all types of routes and opioids. Number one, do consider the last renal and liver function of the patient, as this will have an impact on the half-life of the opioids. So in the event of poor liver function or end-stage renal failure, it is still possible to use morphine at home as well. but we will need to stretch out the interval between medication potentially to 8 hourly or even 12 hourly so as to prevent the opioid doses from stacking up on one another that may lead to toxicity. So this is really based on our estimation of the half-life, which is at least 4 hours to start with. If we think that the renal function is renal or liver function is very poor, and the possibility that the excretion of the medication will take a very much longer period of time, then we will need to drag out the timing that the next dose can be administered to prevent the medication from stacking up and to prevent toxicity. Secondly, if a patient consistently requires 3 or more usage of as needed doses of medication, the practitioner can consider providing regular opioids, and there are various options available, which we will discuss in later on. Thirdly, theoretically speaking, there is no ceiling dose for opioids, and it should be used as uh, as tolerated to patients' comfort, as long as there's no opioid-related toxicity, and up to the level that the patient is comfortable. Lastly, how do we define comfort? Some patients uh, demand that you give me medication until there is no pain, and will keep on asking for escalation or analgesia till that level is reached, totally asking about zero pain. In the setting of palliative care, we believe that as long as the underlying pathology is present, there will always be some form of pain and discomfort. The main aim of palliative care is to allow patients to continue with normal quality life for as long as possible without having much problems. However, in terms of opioids, if it's escalated too fast or too much, this potentially can cause serious toxicity and can impair on patients' quality of life. So within the research as well as clinical setting, usually when we consider what we consider as pain relief is can be either way, that there's a documented 50% pain reduction, or patients feel that the pain is mild to the extent that potentially they can go back to their usual lifestyle, they can do some self-care, they can have some quality of life. But we need to understand that for patients at palliative setting, we cannot have that expectation that there will be no pain. Oh. So let's try to have such an understanding for our practitioners in this webinar and educate our fellow colleagues and patients that there will never be the scenario of no pain in our setting, no matter how much we do. I thought at this point in time, it is important to share with everyone this concept about opioid conversion. As mentioned earlier, morphine is the starting point of strong analgesia and is also a common denominator that we fall back onto when we want to change from one form of opioid to another form of opioid. So, for example, codeine is commonly used in the community setting as a form of analgesia. So its conversion ratio to morphine is roughly about 1 is to 10, or as you can see in this diagram, 30 milligrams of oral morphine equates to 30 milligrams of oral codeine is equivalent to 3 milligrams of oral morphine. So this is the oral conversion ratio. 10 is to 1. So 10 of codeine is to 1 of morphine. So as we know, codeine's starting dose is commonly 15 milligrams to 30 milligrams, which then equates to about 1.5 milligram or 3 milligram, depending which dose that you start with, of oral morphine equivalent. And as mentioned earlier, oral morphine starting dose is about 2.5 milligrams in a syrup form in Singapore. So actually, if you think about it, it's actually roughly about the same, that the doses that we are comfortable with for oral codeine actually is rather similar to that of the starting dose of oral morphine. Which brings me to the point that many practitioners are concerned with regards to usage of morphine for very good reasons, such as opioid abuse, dependency, mismanagement, and patient may start to use it inappropriately. So these are very true and grounded concerns. However, I just want to assure everyone that if used appropriately, actually, the common starting dose of 30 milligram oral codeine is actually more than the starting dose of morphine of 2.5 milligram. So similar something to consider, tramadol lowest dose is actually about 25 milligrams, and tramadol's conversion ratio to morphine is about 5 to 10, depending on how you, what property of the tramadol, what receptor agonist are you using for oral tramadol. So it's roughly about 5 is to 10. So if we use the conversion ratio of 10, then actually 25 milligrams of oral tramadol equates to about 2.5 milligrams of oral morphine. So we would know that codeine or tramadol actually have some side effect profile like constipation and nausea vomiting, which is sometimes actually more than morphine. Hence, if in a palliative setting, if you're seeing someone in a palliative setting, if you want to start a morphine 2.5 milligrams as a starting dose, it is actually something very reasonable. And hopefully, with this conversation, you would be aware that this is something that actually is common to what someone in the community usually will start with. So it's something that we should be comfortable and familiar with. But of course, I understand that the use of morphine, some people may have some concerns, but in the palliative setting, usually it's quite rather safe. So we go on to some other forms of opioids. There's another class of opioids called oxycodone, which is a strong opioid. Essentially, it is two times, if we talk about conversion ratio, is two times stronger than morphine. Hence, 2 milligrams of morphine is equivalent to 1 milligram of oxycodone. Lastly, as we mentioned earlier about morphine as well as the transdermal medication, actually a 15 milligram of morphine is actually equivalent to 6 microgram per hour of transdermal fentanyl patch. So let's take a look at how does this calculation actually work. Okay, with regards to fentanyl, of course, I always tell my patient, especially nowadays, that Trump has been talking a lot about fentanyl. There's a lot of abuse and misuse going on in the U.S. community, but in this setting, that Amma is really very uncomfortable from the breathing and all those. Let's try to use it to make sure that Amma is more comfortable and we go by the usual Jerry Rich kind of doctrine that we start low and go slow. So let's take a look at this. Um, if Amma is taking morphine 6 times a day, that means it's actually 2.5 milligrams of morphine every 4 hours. So this is actually, in a certain sense, the lowest starting dose that we can use for morphine in a regular fashion, taking into account if let's say Amma's liver and renal function based on the last check that we have is actually normal. So if let's say we feel that Amma's breathing rate is actually rather high with a dose of morphine. So sometimes when we start, we can actually give her a dose of morphine first if this is something that she still accepts, and then see what's the effect like. So potentially, if we give the scenario that the morphine actually helps, and after maybe about 4 hours like that, then the family start to notice that the breathing rate starts to come up again. So technically speaking, effectively speaking, this means that the morphine effect has peaked that help with breathing, then it has wear off because of the 4 hours half-life. So this will result in that drop in the more comfortable kind of breathing pattern at the start and then reverting back to usual at the end of the 4 hours. So if let's say they call the HNF hotline and they tell the nurse, now after 4 hours is reverting back to its original state, then potentially you give another dose. And then potentially if this repeats, then it is quite evident that she probably will need a regular dose throughout the day so as to maintain the opioid concentration within the body at a certain level that can help with the control of breathing. So let's say then from this circumstances, we eventually make a decision that Amma requires morphine 6 times a day. In terms of calculation, This will then equates to 6 times 6 multiplied by 2.5, which equals to 15 milligrams of morphine per day. So the MEDD for morphine is actually 15 milligrams. And fentanyl, as we know, Trump is already saying this 1,000 times that fentanyl is 100 times more potent than morphine. But we need to remember that fentanyl's unit is in microgram, which is 1,000 times smaller than morphine's unit in milligram. So potentially, this is how we will calculate it. 1 milligram of morphine is actually 1 divided by 1. So the red color is actually more of the number, numerical. The blue color is more of a units. Oh, so 1 milligram of morphine is 1 divided by 100 because fentanyl is 100 times more potent. 1 over 100 milligrams of fentanyl. Then if we want to change the unit to microgram, we multiply by 1,000. So then this gives a conversion ratio of 1 milligram of morphine is actually equivalent to 10 microgram of fentanyl. I hope this is not too complicated. So then the next will be that, so then this will give us the conversion ratio of 1 milligram of morphine is equal to 10 micrograms of fentanyl. And hence 15 milligrams of morphine per day, which is what we are using, so 2.5 milligram for 6 times a day, is actually equivalent to 150 mics of fentanyl per day, equivalent to 6.25 microgram per hour of fentanyl. So in a certain sense, how I mean, in my unit when I teach my juniors, is that of course, number one, we need to make a decision how much of the opioids does the patient need per day. So this can be in a certain sense from either subcutaneous titration of medication, if not through the NG. Then once we have that daily dose that is required by the patient, the next step is then to see, depending on where the patient will be going, if it's going home, then of course a patch will be better, or if the patient is still able to swallow, then we are able to give morphine either as a syrup round the clock. If not, we can give sustained release tablets as well. So this is in a sense what we try to calculate for the daily dose of morphine. So what I'm trying to share with everyone here is actually that for the lowest dose of fentanyl, this will equate actually to the lowest dose of regular morphine that a patient needs to have in a daily basis. So in a certain sense, the 6 microgram, even though it's a fentanyl, 6 microgram per hour, even though it's a fentanyl, but it actually then falls back to 2.5 milligrams of morphine 6 times a day. And of course, the 2.5 milligram, if you want to see it another way, actually the 15 milligrams of morphine is actually equivalent to 50 milligrams of tramadol, actually at 3 times a day. Or this one we'll do the calculation later on. Let us move to the transdermal route since we are talking about fentanyl patch. So this is actually one of the route that we can use in this case of Ahmad being very breathless and not able to take orally. So transdermal route is actually one of the way that we can administer opioids without injectables. So essentially, what happens when we apply transdermal route to our patient is that it forms a subcutaneous depot, which is then absorbed into the systemic circulation. So as you can see, once you apply the transdermal patch on the top of the skin, by diffusion, the medication then diffuse into the subcutaneous fat and form a depot in the subcutaneous layer, and subsequently from the subcutaneous layer, once the concentration is high enough, it will then diffuse into the blood circulation. So there's this sort of lag time for all these things to happen, which is about 8 to 10 hours like that. Oh. Um, so it takes about 8 hours for the steady state of the medication to be achieved in the blood systemic circulation. So what we're talking about is if let's say you apply a 6 microgram per hour of fentanyl patch on the skin, it takes about 8 hours for the 6 microgram to be circulating consistently per hour within the body system itself. So at times, if let's say Ama is quite breathless or have a lot of pain, and then we have no other choices but to use the transdermal patch, we may then give the patient, if the patient is still accepting, to let her take regular morphine, because regular morphine will then go into the systemic circulation within 30 minutes. So in a certain sense, it's a temporizing measure while waiting for the 8 hours to pass, for the depot to be formed, and for the systemic circulation from the fentanyl patch to be more regular. So at times, if let's say the renal and liver function is okay, we may ask the patient to take another 2 more doses of oral morphine so as to allow the 8 hours to be temporarily covered by the oral morphine before the transdermal patch takes into effect totally. In a hospital setting, where we change from the subcutaneous infusion into the transdermal patch, we will also continue the subcutaneous infusion for another 8 hours before we switch the patient over to a transdermal. What I mean is that we will overlap for 8 hours. We put a patch. 8 hours later, we will then remove the subcutaneous injection of fentanyl or morphine to allow the patch to have its sustained effect. Okay, moving on, we have gone through briefly about oral morphine, which is the denominator that we use for everything that we will talk about later on. And then we'll talk roughly about the use of transdermal fentanyl patch, which I think most people will be quite familiar with. The next part I would like to discuss further on rectal administration of opioids, as this is one of the most commonly used method in care and nursing home. Care and nursing home care and nursing home is now the consolidated term used for for palliative care that originates from hospital, looking at patients in the nursing home. So it can be what we previously called as project care, or the similar entity within the KTPH system. So firstly, I would like to acknowledge Dr. Lawrence Tan from Kotipah Hospital for providing all the information in this slide. So firstly, it is useful to understand that rectal administration of opioids can actually bypass what we call as the first pass metabolism by liver. Hence, this may increase the efficacy or the bioavailability of the opioids administered. However, the absorption can be rather erratic, and only the distal one-third of the rectum flows into systemic circulation directly. So if there's a spillage to the other parts, which is actually expected, so the opioids that are absorbed by the upper two-thirds of the rectum actually then will go through the first pass metabolism by liver. Second thing that we need to be aware is that we need to avoid using rectal administration for patients who have neutropenia, thrombocytopenia, or any form of existing anorectal diseases. Thirdly, the effectiveness, as mentioned earlier, depends on the few issue. So of course, if the patient is very, very constipated, then the morphine will get absorbed into the stools. The patient's hydration status will also affect how much medication can be absorbed. So lastly, anyone of us here who has given rectal medication will know that there's a risk of the medication being expulsed and just leak out before it can even be absorbed. Sometimes, when we give Santa, enema, and all those, we need to ask the patient to hold the medication before it works, then don't let it out. But generally speaking, we know that it's going to be quite difficult. Overall, for the intention of this purpose, we usually give about less than 5 ml of fluid to help with retention in the rectum. So with regards to the conversion ratio, because of all the factors that I discussed earlier, we generally consider a 1-to-1 conversion ratio between oral morphine and rectal morphine. So rectal morphine essentially like the picture is showing, we just draw what is necessary, dilute it with saline up to less than 5 mL, and then we administer it rectally lah. Or wherever it goes, it's absorbed lah. Or we do have evidence that suggests that definitely rectal morphine is safe with a fairly rapid onset action, about 20 minutes, and it seems to be quite effective. So this is the short spiel and courtesy to Dr. Lawrence Tan for providing me on the information for rectal morphine usage. Next, we'll bring everyone further into the advancement in the last 10 years on alternative methods of opioid administration, including sublingual, intranasal, as well as buccal. One common thing before we move forward with these three alternative dosing of opioids, which is sublingual, intranasal, and buccal, is that the patient needs to be on this long-term maintenance opioids, which we will see why later. Also, all of them are FDA approved, and FDA ruling has it that the patient needs to be on long-term maintenance opioids before we can use all this. So, patients also, in a certain sense, patient cannot be what we call as opioid naive, which essentially means the patient has not taken opioid before. So, in the accompanying product information as well as the FDA approval, it is stated that the patient must be taking a daily long-term opioid for a week or even longer. And secondly is how do we then define this dose of maintenance opioid? So it is stated that it must be an oral morphine of at least 60 milligram per day, or transdermal fentanyl patch of 25 mics per hour, or oral oxycodone of 30 milligrams per day, or oral hydromorphone of 8 milligrams per day. Hence, with the maintenance dose, the purpose of using sublingual, intranasal, or buccal opioid is for the sole purpose of treating the breakthrough pain. So you go by sublingual first. You discuss briefly about the pharmacokinetics of sublingual administration of opioids. So firstly, actually fairly similar to the rectal administration of opioids. Using sublingual method can help us bypass the first pass metabolism, that is the metabolism by liver that I mentioned earlier. The area under the tongue is actually highly vascularized, as all of us know. So the sublingual area is actually the most permeable area in the oral cavity. Absorption is within 30 minutes and onset action is within 10 minutes. However, the challenge is that of the bitter taste that comes with the medication and requires the patient to cooperate with holding the sublingual tablet under the tongue for a few minutes. I guess in the example of Amma, that anything that goes into the mouth, she'll spit out, anyone try to touch her, she'll try to punch. It may be a bit difficult. Astral is actually available in Singapore. It actually comes in a starting dose of 100 micrograms per tablet. It then goes up to 200. Next dose will be 200 microgram, 300 microgram, 400 microgram, 600 microgram, and the highest dose is 800 microgram for the purpose of use in cancer breakthrough pain. So of course, in the geriatric and palliative care setting, we do have some concerns that the lowest breakthrough dose is 100 microgram. So in a certain sense, how many of my patients actually use 100 microgram for breakthrough? 100 microgram is actually equivalent to about 10 milligrams of oral morphine as per our discussion earlier. So may not be so suitable for many of our patients in Singapore. That's, I guess, one point. Of course, the other point is that the patient will need to have this long-term maintenance dose of opioids before we can use Abstral. We need to be aware that it is not a one-to-one conversion ratio from subcutaneous fentanyl to sublingual Abstral, really because of the so-called bioavailability of the medication. It is definitely not one-to-one. So subcutaneous, intravenous, actually it is 100% bioavailability because they do not go through first-pass metabolism. But even if sublingual, sometimes some of the medications will go by the liver process. So it's not one-to-one. So essentially, there is a need to titrate using Abstral on its own to assess for its own potency and how much the patient will require. So the product leaflet comes with a titration protocol. So essentially, if the patient has breakthrough pain, we can use the 100 microgram as a for starting dose first, and wait for about 30 minutes. If there's no relief after 30 minutes, then can take a second dose of 100 microgram. And for each breakthrough titration use, a patient can only take a maximum of 2 doses. That means if the 100, okay, I guess in a hospital setting, if let's say the 100 microgram plus 100 microgram doesn't work, then we may need to consider other routes or other medication for pain relief, etc. lah. So at most, in one sitting is 2 tablets only. So then the next usage of Abstral will then be 2 hours later lah. But of course, 2 hours later, if we know that 200 microgram doesn't help, then of course we will start at a higher dose. So in another method of showing the titration process, so we have gone down that flow chart of starting at a dose of 100 microgram, waiting for 30 minutes. If let's say it's not better, you take a second tablet, and then if let's say at the next setting, so that will end this titration for this setting. But in the next setting, if let's say 100 microgram, 200 microgram doesn't work, then potentially at the next setting, the patient may want to try the actual tablet of 200 microgram first, and then subsequently you can step up accordingly lah. Yeah. Okay, next we will go through intranasal. Intranasal administration of opioid is another attractive option because the nasal mucosa is highly vascularized as well, that allows direct absorption of medication with ability to bypass the first pass effect. It takes about 10 minutes for the onset of action, similar to sublingual routes. The bioavailability is about 70%. But we also need to remember, similar to Abstral, that it's not a 1-to-1 ratio. That means it's not like you give 100 mics in the subcutaneous route is equal to you give 100 mics in the intranasal route. So you need to start from zero lah, essentially for repeat process of titration to find out what exactly is the adequate breakthrough dose. The medication is administered via a mucosal atomization device that is directly inserted in the nasal cavity. And lastly, we will need to be aware of potential side effects such as nasal irritation, discomfort, and epistaxis. Of course, we also need to be fully aware of the risk of drug abuse and opioid toxicity. So this is how it looks like. So PECFEN is actually available in Singapore. I think not so much in Tan Tock Seng Hospital, but I think NUH side available in 2 strengths, 100 microgram per spray and 400 microgram per spray. So each bottle allows for about 8 sprays. The doses can be delivered described actually in this table lah. Also, essentially, in a patient who is already on chronic opioid medication, if he's initiated on PECFEN for pain titration, he will use PECFEN once to deliver 100 mics of fentanyl. If this settles, then he use the next spray after 4 hours, and he can only use 4 times of PECFEN per day. So that is first scenario, that if let's say the pain control is better after 1 spray. But if pain is not better after 30 minutes, you can use the PECFEN again. So now is 100 mics plus 100 mics to use total of 200 mics for this breakthrough. The second spray should be administered to the other nostril. So if this 200 mics is not useful, the patient will then be prescribed a bottle of PECFEN 400 microgram and instructed to change to one 400 microgram spray for the next episode of pain. So this episode only 2 sprays, and then the next episode will then jump up to 400 microgram. I think it's quite a huge jump actually. So if the 400 mics is not helpful, after 30 minutes, the patient may be instructed to increase to 2 400 microgram sprays, so 800 micrograms. That's the maximum. Yeah. So each breakthrough can only take 2 sprays. Each time the breakthrough should be spaced. That means this episode and next episode. Once this episode, the 2 times are settled, the next one that you can use PECFEN should be about 4 hours apart lah, and only use PECFEN up to 4 times a day for each breakthrough episode, but each time you can use up to 2 sprays. Lastly is buccal administration of medication. So buccal mucosa is also highly vascularized to allow absorption of fentanyl. There are also mechanisms to escape from first pass effect, but the viability once again is not 100%. So it is not a one-to-one conversion ratio once again. So there are three main routes of administration. One is the lozenges on the handle. Okay, in this diagram, it looks like a lollipop, but actually it looks more like this. It is rubbed against the cheek for over 15 minutes and about 25% absorbed through oral mucosal. Onset action is within minutes. The second one is effervescent buccal tablet that allows repeat absorption of fentanyl within 25 minutes and onset action within 15 minutes. About 50% of the uh, medications are absorbed into the mucosa. And lastly is a film that is held onto the buccal mucosa for about 5 seconds to stick on. It takes about 30 minutes of absorption and onset action within 15 minutes. Go through this very quickly because these are actually all not available in Singapore. Okay, this table essentially summarizes the potential uses of each route of administration in various considerations. So sublingual, rectal, continuous subcutaneous infusion can be useful in our palliative setting when patients are vomiting, having intestinal obstruction or dysphagia, where they may not be able to, take the medication orally through the enteral route, and when there's no parenteral choices, yeah. So those with delirium, it may be difficult to use sublingual as well. And of course, those with lower GI issues like hemorrhoids, fissures, diarrhea, then rectal is not one of the consideration. I'd just like to share some interesting studies that I found through some search. So this article was published in the BMC Palliative Care in 2024, essentially looking at fentanyl administered via inhalation through a thermally generated aerosol compared to placebo. So aerosol administration of fentanyl compared to placebo. So it concluded that treatment with fentanyl inhalants, so maybe something like a net, that kind of setting, is useful. With a significant difference in pain score after 30 minutes. So effect onset about 4 minutes and may last about 60 minutes. I think these are exploratory pilot studies, so that's why I think it's probably need to take some time before the product can actually comes out into the market. There is also another study in 2009 comparing intranasal fentanyl spray with oral transmucosal fentanyl and essentially showed comparable results. So there are about 500 plus pain episodes treated with either, that means intranasal sprays or oral transmucosal fentanyl. More patients in the intranasal spray group experience faster onset of pain relief than the transmucosal group. So significantly, greater proportion of those in the intranasal group achieve about 50% reduction in pain score as compared to the transmucosal group. So general impression from the study as well as from the population that is being studied is they are more in favor of the intranasal fentanyl spray group. Okay, lastly is just a very, very short spiel on what we call as the epidural and intrathecal options. Or these are sometimes some of the options that within the hospital setting that we may consider administer, so that at the end of life, there may not need to have parenteral administration of medication for patients. So between epidural and intrathecal, epidural usually is for patients with shorter prognosis, really because that is associated with high risk. So as you will probably be aware, the epidural injection actually injects into the epidural space. It doesn't reach the blood-brain barrier into the intrathecal space. But actually, it's more superficial, higher risk of dislodgement, as well as higher risk of infection. So then the volume that needs to be given is actually uh, slightly higher, so there's more need for frequent refills, meaning that usually what happens after the patient has that device being inserted is that there will be this pump that will be attached to the patient and the medication within it. So if let's say the patient is discharged to the community, then the patient will need to come back, or the family will come back to the hospital or the clinic setting to collect medications and refill the pumps. In the intrathecal setting, nowadays, I think we are looking towards patients with longer prognosis, really because that although I mean, in a certain sense, theoretically speaking, we are invading into the intrathecal space, but nowadays I think it's rather safe, and with the experience that the hospital anesthetic team has, and there's also associated with lesser risk. So implantable intrathecal pumps, so similar to like the Palliative that we see for some of our other patients, actually available. So this can actually reduce risk of infection as well as dislodgement. And the other advantage is that lower dose of medication is needed because it goes directly into the intrathecal space, so less need for diffusion through the blood-brain barrier and all those other barriers that may require higher concentration of medication to be administered. Yeah, so there's less need for frequent refills, and potentially this can benefit patient and improve their quality of life for those with longer prognosis. And of course, theoretically speaking, because we are doing an injection into the intrathecal, some people may have worries that of paraplegia, weakness in the lower limb. Of course, technical risk is always there, but with regards to, but let's say there's a technical success, with usage of medication, actually the risk of weakness in the lower limb is actually very, very, very low. So this one is something that I think my pain team, my chronic pain service in Tan Tock Seng has been nagging at my team, because I think my team is probably a bit more pessimistic and uh, worried lah about affecting patients' lower limb function and quality of life. But they've been telling us that no, actually the risk is very low. You've seen so many cases that we have done for you and your patients, and actually the risk is really very low. Yep. Okay, we come back to the case of Amma again. So, as part of the IHH NRI protocol, the family actually has obtained a transdermal fentanyl patch for her lah. So, actually, her breathing got much better after we started the patch for her. Then, of course, coming back, actually, we want everyone to just recall that 6 microgram per hour of fentanyl patch is actually equivalent to 15 milligrams of oral morphine per day. And actually, if you look at the numbers properly, um, actually 15 milligrams of oral morphine is equivalent to 50 milligrams of oral tramadol 3 times a day. So this is something very fairly common that a lot of us prescribe to our patients, even with no end of life issues lah. Yeah. Okay, so in this discussion, we have discussed various means of providing opioids other than the intravenous and subcutaneous routes. So by far, I feel that the most practical and available routes in Singapore is still the transdermal routes, as well as rectal measures. It is something that is acceptable. Potentially, intranasal sublingual can be used. These are medications available in Singapore, but there's a requirement for the patient to be on a long-term and high dose of continuous opioids before we can start all this. And of course, the starting dose for these medications are quite high actually, as a breakthrough dose. So we do have some concerns, and I think we need to know more. We definitely should and will want to know more and use it for some of our patients, gain some experience in all these things before we start, you know, using it more frequently. Yeah, and these are some of my reference for as well. Yeah, thanks very much for everyone spending this Saturday afternoon to discuss with us. Thank you.
Thank you, Dr. Goh. That's a very, very comprehensive overview of all the oral, non-parenteral approach to treating pain in terminal situations. There were some questions that are mostly administrative, but there was one question from the last person who asked it. I just wanted him to clarify a little bit because it's not very clear. But I have got some questions for you. Say that Ama is having acute pain. Say he's shouting, grimacing, and then you put on a fentanyl patch, but it only work in 8 hours, and there's no NG tube. So how would you manage the pain immediately?
I think like what we discussed, options are actually rather limited. One of the more evidence-based, and I think what we practice a bit more will be rectal administration of opioids. So if in such a scenario, if we consider a 2.5, if let's say we are using morphine syrup, we can actually draw 2.5 milligrams. If you
Oh,
want to dilute it a bit more, maybe up to 3 mils or less than 5 mils lah, and then administer through the rectal routes lah. Yeah, I think within the HNF setting, we have tried to explore with regards to usage of sprays. Yeah,
yes.
but I think there's limitation. Number one, I mean, one is that from literature evidence, not exactly too sure, but we do see from the other evidence that it is a potential route of administration because of the vascularity and all those things. But how much can we spray? How much is being absorbed, and how effective it will be? I think these are some of the questions that we have in mind. But we did try. Oh, uh,
Did it
yeah,
work?
we did. I think I think the main thing is we aren't too sure how much per spray, how much
Yeah.
morphine we are giving per spray. Like, I think that one will need to go back to that bench examination of how it works. Yeah. Yeah,
Yeah.
but theoretically speaking, I think it should still work. Yeah.
But what kind of preparation? Was it the
Mm.
mist morphine preparation or was it the injectable morphine preparation for the nasal spray use? Which
For
one?
the
For the
okay, I
intranasal.
can't.
Yeah. I mean,
Okay,
of course,
this
the
one I can't
fentanyl.
recall. Yeah, yeah,
Yeah, in the fentanyl intranasal you mentioned earlier is for people who are already like opioid tolerant.
yeah.
And so for people who are naive to opioid, we can't really quite use that. But you can, but you mentioned you try intranasal morphine, right? So Miss Morphine
Yeah,
or is it? Yeah,
I think if I recall correctly, should be Miss Morphine.
Miss
Yeah,
Morphine.
yeah.
Okay.
But I also know that I think HCA actually
Yeah.
uses injectable fentanyl and
Uh-huh.
essentially syringe it out and then put in the sublingual area. Yeah, that
Okay.
is potentially another.
Yes,
Well, of course,
yes.
I didn't present all this so-called unorthodox way
Yeah,
lah.
these are very unorthodox.
Yeah,
Yeah.
yeah. But this is another route of administration that potentially we can consider as well lah. Yeah,
So this is a bit related because we're talking about unorthodox practices. Many years ago, there were people talking about, when there's terminal agitation, we can just pound the Ativan or the lorazepam, and then dissolve in water. About 1 ml or 2 ml, put it under the tongue. Is it something that you have tried? And what is your thought about this?
Mm. Actually, I thought that lorazepam is actually we can administer through the sublingual route as well. I think it can
Mm,
dissolve, but it's just about the um, cooperation of the patient to hold the medication under the tongue. Yeah, yeah. The
yes,
other one that potentially we can consider is olanzapine.
yes.
Olanzapine can actually be used as a sublingual route as well. Yeah. Yeah,
Okay.
yeah, but of course, like what you mentioned, I think in the community, definitely we need to be very creative about things.
Yes.
Yeah, so
Yeah.
pounding and then diluting, these methods can definitely be tried as well. Yeah,
Mm, mm.
yeah, especially towards the end of life. Sometimes, I think symptom control is very much more important. Yeah,
Yeah.
yeah, than all this
Yes.
academic. Yeah,
I have one last question. We do receive patients who have been titrated and stabilized on fentanyl patch,
yeah,
but not really terminals for some other pain control.
yeah.
And then over the years, we would just continue with the same dose, and the patient somehow goes back for follow up, and the hospital specialists continue with the same doses. It's not very high, but sometimes we're not comfortable because the condition that required that had already resolved. We believe
Yeah.
so, and so we want to tail it off. Is there any recommendation? How do you tail off people who are on long-term fentanyl patch?
Uh, I think really is a balance. Okay, it's a balance of how it's sort of in a balanced discussion now because we are also wary that if we tail, then sometimes the symptoms may come up again. So I guess
Yes.
that's potentially why some people may still continue. But of course, if let's say we are quite confident, then theoretically speaking, we can try a stepwise kind of approach, which
Mm.
the lowest change that we can do is actually a 6 mics. So
Ah,
potentially, like let's say 12 mic, the patient is on 12 mic, then you may want to consider cutting 6 mics. That means
and the
you
person
put in
can
a
take orally. Then we can give
yeah,
some syrup morphine
yeah,
as well. Yeah.
to tide through,
Mm.
like let's say there's some breakthrough pain and all those things. So we cut down to 6 mics, potentially for another week, or to
Mm.
hold the 6 mics for another week. Then if let's say the pain is actually gone already, then we just take out the fentanyl patch. I think this is something possible as well. Yeah,
Mm. But there's a possibility of dependence, right? If they are on
yeah,
it for so long.
yeah.
Yeah. Okay. So we don't have any other questions. Maybe I will just try the anonymous person who asked this question is oh yeah, he said, is lidocaine really helpful in lessening the pain of the patient during insertion of FC Foley catheter? Uh, I think okay. So somebody asked a question about lignocaine
Yeah.
as an LA for Foley's catheter insertion. Yeah, I think FC is Foley catheter, but
Should be,
yeah,
should
it
be,
should be right.
yeah,
Yeah, I think so.
yeah. I think the cocaine, I think we are all quite aware that it's local anesthesia, lah.
Yeah,
Yeah.
yes, yes.
So theoretically speaking, it should help in some ways or another, lah. But I'm not exactly too sure why is the question specific for catheter insertion.
Yeah,
Yeah, maybe there's some consideration with regards to with regards to the urethra tract, whether there is really I mean because the pain receptors usually more superficial, then
yeah.
whether or not deeper inside with regards to other forms of pain mechanism, whether is it really helpful or not. Yeah.
Yeah,
So this part, to be honest, wouldn't be exactly too sure about this, but I think generally speaking, we will all accept that is local anesthesia. It should be helpful, right? Yeah,
I think so too.
yeah.
Okay, so maybe with that we can close the session. Thank you very much, Wen Yang, for your generous sharing today, and I'm sure all of us here we have 277 at the peak of the audience today. Must have benefited from this. So thanks a lot, and everybody have a good afternoon and a good weekend.
Thank
Okay,
you very much. Thank you. Bye bye.
bye bye.